the VP of Health Center Operations. I'm Catherine Moore. I'm a family practice doc, and I'm one of the doctors involved in the chronic pain program.
I am Dr. Kernan, family physician, doing chronic pain and also medication-assisted treatments.
Sandra Griffin, clinical case manager and medication-assisted treatment program.
And I'm Rajiv, manager of behavioral health and BHC.
I'm Dr. Patshala. I'm a family practitioner who's doing chronic pain and also the MAC program here.
Okay, thank you. Well, it's nice to meet all of you. I'm Debbie Richardson. I'm in Kansas City and with the University of Missouri, Kansas City, and serving as the state targeted response for opioids technical assistance specialist, and bringing you this training opportunity this morning. And I'm going to leave Colleen for last, but Lindsay, I see you're on the line as well, or on the video conference, and I've heard your name, so it's nice to meet you. Would you like to introduce yourself, please?
Sure. Hi, I'm Lindsay Hoslog, and I'm with the Missouri Primary Care Association. And Dr. Tapey invited me to listen in this morning to learn what Affinia will be doing and seeing if this can be replicated with some of our other community health centers across the state.
All right. Thank you, Lindsay. Well, I know we've got our main program this morning. We want to allow a lot of time for that. And so I do want to let you know that I'm going to record this. I've already pressed record, so let me know if you have any concerns with that. I don't know what we'll do with the recording afterwards, but thought maybe some of you all at Affinia may want to have that in case you had other staff unable to attend this morning. So I'm going to turn it over. Our other our guest consultant trainer this morning is Colleen LaBelle, and Colleen is with the Boston Medical Center, who's another key partner with the national STRTA work that's going on across the country. And Colleen, I'm just going to turn it over to you to explain further what all you do there, and go ahead and launch into the presentation this morning.
So good morning. Thanks everyone for coming. First, I'm going to ask if everyone can mute their line, because I think that there'll be less feedback and hopefully the sound will be better. Debbie, your sound, by the way, is really not great. I'm not sure. Can everyone hear me clearly? Can I get a thumbs up if you can hear me clearly? It doesn't sound crazy. We got to work on Debbie's sound.
Okay.
All right. Perfect.
All
right. So Debbie, if you could mute your line, just because it definitely helps with the transmission when we do the Zoom calls. I've learned this from experience of our own bad steps. So with that, what I was going to do is kind of walk through a little bit on the nurse care manager model and why we're here, and then from there open it up to questions, which I think are much more valuable than me just talking the whole time. So my name is Colleen LaBelle. I run the office-based addiction treatment program, and if you can't hear me or something, make some sound, some sign or something so that I can stop blabbing. So I run the office-based addiction treatment program at Boston Medical Center. I started the nurse care manager model here back in 2003, and then we expanded it across the state with support from the state into community health centers. So I now oversee 42 community health centers that have models that are modeled after our nurse care manager model, and it's also being implemented into other state systems and other community health centers. We also have a NIDA expansion grant, which is looking at 6 health systems across the country, and if using nurses is a way to really facilitate access to care, which to me feels like a no-brainer, but we're here and we're going to try to figure out how to help others do that seamlessly. I think that's the trick. We know that it works. It's just how do you do it? So I just want to start with this slide. I know some of you are doing addiction work, some of you are just getting your feet wet, some of you have been doing this for a while, but Nora Volko, who's the director of the National Institute on Drug Abuse, which needs to change their name, said, in all my years as a physician, I've never ever met an addicted person who wanted to be an addict. I think we all need to sit with that, because I think that's a loaded statement and so important for us to all keep in mind when we're treating patients with substance use disorder. And so why are we here? How did we get here? You know, everybody wants to blame people, and people love to blame the doctors. That's like the favorite thing to do, right? And so there was this rise in opiate prescribing, but there also was, you know, these new methods of how you treat pain, and there was these new quality metrics of how do you treat people's pains, and if you're not doing it, what happens? And people were being measured as well as reimbursed based on meeting the fifth vital sign, as we all know. Then there was this rise, then since then with the rise in prescription opiates has then created a rise in heroin use, which created an increase in overdose deaths. And then people unfortunately are either and further transitioning from heroin to other synthetic drugs known as fentanyl, which is familiar to most of us, as well as carfentanil, which are much more powerful and are creating really instantaneous deaths in lots of cases, which is why using other tools such as Narcan is such an important factor. So our prescribing has gone down, probably the pendulum swung a little bit too far, most of us will say. But now we have people that are literally starting their use with heroin and fentanyl and other things that they are not quite sure of the purity or what is in those drugs from the market. So substance use, as we talk about, is a disease, not one that the medical community as a whole has done a really great job treating. It hasn't been something that's been reimbursed well. It hasn't been something that's been integrated. It hasn't been something that's been taught about. And frankly, it was something that you just sent somebody to go see their counselor or go to detox or get a bed. But in healthcare, it's a place that we need to do a better job. And this just shows you that gap that only 1 in 10 who have a substance use disorder are actually in treatment. And some of that is related to the healthcare field not having the tools and not having the knowledge, as well as the stigma, and people just, you know, falling under the radar for a really long period of time. But we need to find a way to change that, to get people into care earlier, and also to get people in before they actually develop, you know, a substance use disorder. If we will look at, everybody's probably tired of hearing the diabetes comparison, which I think they are here. But if we looked at other chronic relapsing diseases, substance use disorder actually has similar, if not better, outcomes when we treat it than those of diabetes, hypertension, and asthma. However, we don't do, as I said, such a great job getting folks in care, but the relapse rates are similar. The outcomes are similar, if not better, but we never would ever talk about any of those other diseases as chronic relapsing diseases, although they all have behaviors attached to them, which is why you can compare them. So the diabetic may make choices not to take care of themselves and not to do their foot care and to continue eating hot fudge sundaes and not checking their sugars and not getting their insulin. And the hypertensive may continue to drink and not manage their diet or stop taking their meds, you know, and the asthma may continue to keep smoking, you know. So those are the behaviors that fuel the acuity of their disease, much like the persons with substance use. And as we all know, behaviors are super hard to change. You know, how do we change behavior? And we all know January 1st, everyone goes to the gym. How many days after January 1st are people still at that gym? So this just to understand that substance use has been around a long time, and physicians were actually not allowed to treat people with substance use disorder way back in the early 1900s when it was against the law to treat someone who had an addiction with
Colleen,
Yeah.
it looks like there might be a question.
Yes.
You know what? We actually are having a technical issue. Can you give us 3 minutes?
Sure.
I really am sorry. Thank
No
you. so much.
worries.
We just have to swap over internet. We'll be right back. Okay. We'll be right back.
It's like a commercial.
It is a commercial, definitely.
A live commercial.
I'm gonna disconnect.
Okay, you want me to disconnect here?
Yeah, go ahead and
Yeah.
shut it down.
Debbie, could you hear me with the volume okay?
Sorry, I was muted. Yes,
That's okay.
very well.
So the volume's okay?
Yes.
Okay, perfect. It's so hard to tell.
Audio. Okay,
You're back.
we're back and we are good to go. We are not going to have any more commercial interruptions.
Oh, come on.
We're gonna mute ourselves. Thank you so much for understanding.
No worries. Okay, so back in the 1900s, the Harrison Narcotics Act made it against the law for physicians to treat patients who had an opiate use disorder, and actually narcotics were banished and destroyed. But back then, they actually understood that addiction was a disease. I mean, they didn't understand that it was a disease, so it didn't get treated. And they had the criminalizations, which is much like we're still, kind of battling this. Trying to medicalize this disease and have people understand that it is in fact a chronic disease. So I like to talk about detox. I don't know in your state what the detox deal is. I know some states have very little detox. In the state of Massachusetts, we actually have an abundance of detox, and some people would argue that we don't have enough beds. But I think the important thing to understand is detox is just that, it's detoxification. It's essentially taking someone in an acute phase and taking the drugs off to deal with the oversedation that may be occurring, but it doesn't treat the disease. And so if you went into your emergency room and you had chest pain, you would get what we would call the Cadillac workup. You would be admitted, you'd have a stress test, a cardiac cath, you'd see a nutritionist and a pharmacist. An entire care plan would be put together. Your meds would be ordered, prior auths would be done. They'd be probably delivered to your bedside before you were discharged from the hospital, with cardiac rehab and follow-up appointments. And you'd be walking in the door at home, and your phone would be ringing, and the visiting nurse would be calling you. That's treatment. And that's what we need to move somebody who has substance use disorder treatment to, that place, because without those seamless bridges and those continuity from that inpatient setting, from that acute admission to an outpatient practice to a place where people are taking care of the disease, we're not going to get good outcomes. And some of the reason for that, people would say, well, they just need to go to detox. They just need to go cold turkey and just get rid of the drugs. But we know that when someone uses substances, that they literally have brain changes. And even if they go to that detox, if mom spends $30,000 and remortgages her house and sends the child out of state, they come back and they're back in that environment. So it's people, places, things, environmental cues that create this trigger for many folks. And also this uncomfortable feeling in their own skin, this inability to experience pleasure, feeling distress, feeling anxious, depression, that can create a relapse, which can be, fatal in a lot of cases. So treating somebody and treating that whole person, or if somebody does choose to do abstinence, making sure that you do wraparound services and deal with their mental health issues and their sleep and their anxiety and the other things that may be going on, so that we don't have bad outcomes. So we know that we have 3 evidence-based medications, 2 with a lot more history and literature than the third, but this is all we have. And so can you imagine having your hypertensive patient, you only had 3 agents to treat them, or even your cholesterol patient? So we have a full agonist, a partial agonist, and an antagonist. And only 2 of them we can treat in a primary care practice. Methadone has to be in a methadone clinic under federal regulations. And buprenorphine can be in your practice setting, but can only be by a prescriber who has a license and a waiver to do this. And naltrexone can be done by anyone who has prescriptive authority in your practice as well. So we know that these meds work. We know that this treatment changes lives. We know it decreases use. We know it improves outcomes, quality of life, criminal activity. People aren't sharing drugs and having unprotected sex because they don't need to fuel their disease. And so they do a lot of these risky behaviors to manage their substance use disease, or to get other drugs to manage their disease. People are getting back to work. Their quality of life is improving. This is just one quote from one of our many amazing patients, and our patients are so amazing when you see the outcomes they have. One says it's the difference between just living and having a life. We have one that talks about it's the difference. I don't have to choose drugs over my children. And that's literally what happens. That person can't make that decision to manage that child because their disease is so powerful. So we learn so much from our patients, and our patients give us so much in return when we do treat their disease. So medications save lives. So again, this just shows you, this is a study that came out of Baltimore that showed patients on methadone and buprenorphine, and that they had 50% less likelihood of having a fatal overdose when they were treated with those 2 medications. Again, we have a lot more data on methadone and buprenorphine than we do on naltrexone. That's kind of been newer to be used in a less volume of patients. So there's not as much of literature on that thus far. The other thing we know is that the majority of our patients are not in care. So this shows you patients that actually had an overdose and hit the health system. This is in Massachusetts from our Chapter 55 data. So it shows you that less than 6% of patients were on methadone or buprenorphine at the time of an overdose. And naltrexone was even lower. It was less than 1% of people were on it. But then you can see that event that was an acute event, how few then still went on to get these life-saving evidence-based medications following that acute event. So that would be comparable to your patient showing up in an emergency room and having that chest pain and walking out without aspirin. 98% of those that have that event leave the hospital with aspirin, compared to less than 6% getting methadone or buprenorphine and less than 1% getting naltrexone. So we now know that we are very fortunate in that CARA expanded access to not only allow physicians to treat patients with these life-saving medications, but now for NPs and PAs. The NPs and PAs require a little bit more of a lift. And again, I don't know the laws in your state, and I apologize, I should have looked that up. But some states NPs cannot prescribe. I'm not sure if yours is one, but hopefully not. But they still have additional restrictions. But more and more NPs are becoming waivered. The PAs are a little bit smaller because it's a smaller group, but they're really stepping up and seeing this as something that they can do to help. And I think a lot of that's due to the fact that a lot of our NPs and PAs are working in primary care, are in these practice settings, or in rural areas, or in community health centers. So they're at places where they're seeing patients with substance use, and they can make a difference. Actually, the NP group and PA group is growing faster in the primary care setting than the physician group. Less physicians are going into primary care practice at this time. And this just shows you, just highlights the states with physicians that are waivered to prescribe buprenorphine. And I just pointed out because physicians have been able to prescribe this medication since 2003, and less than 42,000, actually we're up to 44 now, 44,000 physicians across the country have made a conscious decision to treat this life-threatening disease. And in Massachusetts, which is a small state, we only have almost 40,000 physicians. So that's like 1 to 3% of physicians across the country are treating this disease. NPs, since they started, this is a really small sampling because it's a really small group of folks, but this just gives you an idea. There's like 1,400 PAs, my apologies, physician's assistants that are waivered to prescribe buprenorphine. In addition to that, nurse practitioners, which seem to really be stepping up and joining the crowd quickly here, and this number is over 6,000 now. So the NPs are really, really stepping up, and actually there appears to be a direct correlation when you look at the NPs across the country and you compare the states with the highest percentage of NPs prescribing. They're comparable to NP states where there's non-restricted practice. So again, the barriers that continue. So you may be able to put in your state, but you may have a restricted practice, or you may have restriction on opiates. And so those states are having less of an uptick than others. So we know patients are able to get the same quality care, whether they're being seen by an NP or an MD, and the research shows that, so that it makes perfect sense to be engaging NPs into this work. We know that medication works. We know that we see decreases in hospitalizations. We see decreases in emergency room visits and decreases in overdose as well as cost. And if nothing else gets anyone's attention, the cost gets the attention. So I showed you the Baltimore study that showed a 50% decrease in mortality. We're also seeing decreases in Medicaid expenses of 33% over a 3-year period on those that are engaged in treatment. So again, it's kind of a no-brainer. When we treat people, they get better, and they do better, and they have better outcomes. So why would we not treat this disease that's costing literally billions of dollars a year? And some of that leads to this, and that is that this is hard to do. And we can't undermine the fact that this can be really challenging, and treating patient substance use disorder in your practice is a big lift, especially if you don't understand the disease or you don't have the infrastructure. This study we did back in 2008 is we surveyed waivered providers to see why people were or weren't prescribing and what the barriers were. The number one issue that we ran into was people were saying they didn't have the nursing support, the office support, and then the other being they didn't have the knowledge base. And so this again speaks to the value of adding nurses to work paired with your providers as a complex care management team and manage patients with substance use disorder. So talking about models, so we are only using one model. Our model is the nurse care manager model, but models are guides and they're pathways to help us get our patients into care. And a lot of it's taking little trinkets from different things that may work in your setting, because where you are and what your limitations and what you can and can't do are very different than what can happen in the state of Massachusetts. So they're models to guide us, but they can be very different depending on your infrastructure, your cost reimbursement, your support staff, and what have you. So the model we developed is the nurse care manager model. And I talked about NPs before, but I'm talking here about RNs or RNs and /LPNs who can manage patients in a primary care practice setting, not who have prescriptive authority. So we developed this complex care management model, and it's been since dubbed the Massachusetts model by SAMHSA as a way to integrate treatment. We then looked back at it. First, we did it in our primary care practice, and then we retrospectively looked at the data to see what happened to our patients. And this study that we published shows you those that were successful in treatment at 12 months. So we had greater than 50% were engaged in treatment and successful at 12 months. But if you counted those that went to methadone, we almost get to 60%, but they made us tease that out when we published the analysis. But as we all know, I mean, methadone is successful treatment if that's what works for a patient. Everybody needs different levels of care. And 49% were retained in treatment at 12 months. This was using the nurse care manager paired with the prescriber. So the nurses were essentially the front line. They are the key that's, they're the glue person, so to speak, the person who's seeing the patient, doing the screener, doing the intake, managing the day-to-day issues that are coming up, the prescription refills, the missed appointments, the pharmacy issues, pain, pregnancy, surgery, social determinants of health. You know, if we can't help somebody, you know, find some way to stay tonight, or how to get their copay for their script, or how to deal with their prior auth, or food and those sorts of things, then things are not going to go well. So the nurse manages a lot of that and also utilizes other navigation supports and care coordinated providers that are accessible depending on the setting that they are in. So after we did our nurse care manager model at Boston Medical and we saw it as being effective, the state was looking at this saying, wow, here's a way we can get providers to do this. And so they actually implemented this training and technical support system in Massachusetts. And what we did is we then started helping the community health centers get going. Similar to what you folks are maybe doing now, is like getting some training and technical support. So we did this in the health centers, and we saw that it increased the numbers of providers that were waivered by 375% in 3 years. And then it increased the admissions to the program from less than 200 to 1,200. And patients stayed in care. I mean, I think that's like the most valuable thing here is we actually got better outcomes in patients remaining in care. We had 65% at 10 months. We actually since have looked at that data and we're at 67% at 12 months. So when we used nurses as well as the rest of the complex care management team, we were able to keep people in care on their meds for longer periods of time. We were able to expand those that were wavered. So we had to start, when we started at sites, I had to be willing to get at least 2 providers wavered, but those numbers dramatically increased. And we were able to get more and more people into care. So we weren't limited by a provider who's only in clinic 1 or 2 or maybe even 5 days a week, but that provider can't manage many more complex patients because their panels are pretty full, they're overburdened, they don't have the time to do all that extra work and deal with a lot of complicated patients. So by using the nurses, we were able to do that. So the MASS model, again, uses nurses paired with physicians initially, but now it's also PAs and NPs in primary care settings, and they were mainly based in community health centers. I feel like the community health centers are so far ahead of the hospitals and the acute care settings in doing this work. We also collaborated with a lot of pharmacists in different settings, and that's expanded since we've started doing ACO level of care in Massachusetts. We showed that when we did the training and technical support, our training and technical support has increased dramatically over the years. And then we've been able to take the model into other settings. We actually have published the model in the AHRQ guidelines. There's a model guideline in AHRQ, which lists like, I think, 12 different models of care. So if you're looking for, what works in your setting, I think, again, taking bits and pieces of different things can be more effective than saying, oh, I'm going to do this, but I can't do this because I don't, have X, Y, and Z. So again, looking at the different models can be really helpful. So the other thing we did is we looked at a snapshot recently and 3 months of healthcare utilization over a 12-month period of time of patients that were in care. And the green bar is showing patients in treatment for less than 12 months, and the orange bar is showing those in treatment for greater than 12 months. And so what we showed is that at 12 months, we decreased the incidence of somebody ending up in a detox. We decreased the incidence of somebody ending up in an inpatient stay or showing up in an emergency room. The longer somebody's in care, the better they do, the better their outcomes, and the better the healthcare utilization. We also developed a clinical guideline, which we're happy to share with all of you if you don't have this yet. We used to call it a policy and procedure manual. We have since moved to the point where we're helping guide people, and we're also helping guide people's care. We've become much less restricted. It's more about keeping people in care, more of a harm reduction approach, trying to keep people alive, because we know that when people aren't in care, people die, and people who are dead don't recover. So our goal is to try to keep them in care, keep them safe, as long as the risk doesn't outweigh the benefit. So we have these guidelines on our website, which are accessible to all of you. And you can see them there. If you want them in a Word document, we can send them to you so that you can tweak them to your settings so you're not reinventing wheels, which doesn't need to happen. We have both a Massachusetts model And then we further took that model and we made it into a national model. And the national model is more adaptive to people in other states. And like I said, we can send it to you in the Word document and you're welcome to utilize that. As well as our clinical tools are on that our website, our intakes, our screeners, our follow-ups, our consents, our treatment agreements are all accessible to you. We've also leveraged technology, kind of like we're doing right now, using things such as Echo and Zoom technology and doing video conferencing with different sites, doing didactics and case-based learnings, which I think are very useful. We actually just had an Echo this morning prior to this call. We already talked about that. So again, we have to really change how we're doing things, more of a harm reduction focus. We're doing a lot more treatment on demand, treating patients when they walk in as opposed to making them jump through 20 hoops. I know you guys are just starting. I'm just telling you where we're at. Utilizing our NPs and our PAs and trying to engage more providers into treating patients with substance use disorder, I think is of huge value. So with our model, how we do it is we screen our patients, and we screen them in person or by phone. If they're not within the office, we will typically just screen them by phone. And essentially, if our patients come into us asking for buprenorphine, which is usually what they're showing up asking for, unless the risk outweighs the benefit, we're going to treat them with buprenorphine. Because we want to keep people alive and keep them in care, and we may not tool, but let me also tell you that our patients will prove us wrong time and time again. So we will screen them, but we will try to engage most anybody we can in the treatment, because you have that opportunity to now develop a relationship. And if it doesn't work, you have developed a relationship, and maybe you can then engage them to use a higher level of care that they may not have been willing to think about before. So how our program operates is the nurses do. Yesterday we actually had what we call an essentials training, where we talk through with nurses how to manage patients in their office settings. The nurses do the initial screener, they do the intake, they provide patients with education, they teach patients about their disease, about the medication, about the program, how it's going to work. Let them know what it is we're going to expect of them, and then we need to make sure that what we expect and what they're able to do are going to match, and whether that's whether that team synergy is there. Can the patient not get there because you're only open 8 to 4 and they work until 5 every day? So it's a team approach, and it's not just about what we can offer, but what the patient can do. We coordinate the care with the office-based addiction treatment providers, collaborate with physicians and pharmacists. Pharmacy is a great tool. Developing relationships with your pharmacy is really important because your pharmacists are out there and they have the eyes and the ears on the ground, and they may see things you don't see. And also we want to help our pharmacists understand the disease and treat our patients more appropriately, because sometimes they may not like taking care of our patients. So really trying to engage them is important. And dealing with insurance issues. So the nurses do those things. We also work on a lot of things around safety and storage. You don't want this medication ending up in the wrong hands. You don't want it not secured. You want it in containers that are child-proof. And people will break a tablet, put half in their mouth, go take the shower, and the kid picks it up on the table. I mean, this medication gets absorbed in the mucosa. So if a child puts this in their mouth, the outcomes can be really devastating. If somebody were to get exposed to it, we ask them to call poison control and show up into the emergency room to have that child evaluated. We actually developed a brochure for this, which we can share with you, but it's mass-based. But it could be a guide for you to help develop one yourselves. We give this to every single patient we treat, so that patient understands the safety and storage, not just of this medication, but of any medication, but of controlled substances for sure. So it's important to educate. We want to protect this treatment. We don't want to lose this important tool. So in protecting the treatment, we need to protect others at the same time. So I started talking about nurses. So nurses do that initial assessment with the patient. They'd review the medical history, the substance use history, the past medical, the psych history, treatments, what's worked, what hasn't, the treatment agreements, what we're going to expect of them in that clinic setting. We talk to them about our urine drug screening, and we get their labs. So we have all this as like a protocol so that the nurses can do this without the provider being present if they're doing those first visits for you. And the providers love this because now we send the patient off to the provider and everything's been done. The nurse has taken the history, the nurse has done the education, the consents, the treatment agreements, and the labs are done. Everything's like neatly packaged. And the provider literally has to sit with that patient, review all that, make sure everything looks okay, and declare that the person has a DSM-5 diagnosis for opiate use disorder, because they're the prescriber, as well as that this person's appropriate for office-based treatment. So again, makes this a really easy lift if you're working in a team-based setting. So the provider does that and assesses all of that, and then essentially works with the nurse or the team, or the nurse and the team, to then develop that treatment plan for that patient. And with that usually is when the induction would happen. So inductions, people get really worked up about. If you haven't done this a lot, there was a lot of hype on this in the very beginning, and there still is in some settings. But the thing that's important to know is, first of all, it's not a big deal. You don't need a special room. Someone doesn't have to sit and stare at everybody for 8 hours. You know, and most of our patients know how to do this better than we do. But it's essentially just making a plan for when that person's going to stop using their full agonist to then transition from that to buprenorphine. And some of them may have transitioned and may be using it on the street. So again, talking to our patients are our best information. They will tell you the real thing if you have those open conversations with them. But you're also asking them now, if your site doesn't have, if your location doesn't have a whole lot of access to buprenorphine, which it may not, they have to trust you in making this transition from a full agonist to a partial agonist and not going into withdrawal. So instructing them on it, talking to them through that, being supportive for them, helping them with that is really important in that process. I just put this in here because when people get worried about how you do it, I mean, like the best indicator to me is dilated pupils. Most people's pupils are dilated; they're pretty much ready to go. But you do need to do, a cow scale on them, assess them, know when they last used and what they used. And what they used is also super important, because if they're using something like a full agonist, like if they're using something long acting like methadone, it's going to take longer to get them to the point of being able to start. I mean, patients typically can start buprenorphine, 6 or 8 hours after their last dose, some of them even sooner if you go really low. But if they're on methadone or methadone maintenance or street methadone, that period of time is longer, and it's really important not to start somebody too soon. So once the patient does get started, so with that protocol that you put in place, like the patient literally comes in, sits with the nurse assesses them, screens them, the patient self-administers the medication, the nurse is not giving them the medication, they can't prescribe or dispense, the patient's taking their prescription medication according to the prescription. The nurse is just guiding that process. So then the nurse sees the patient, and again, this is very case dependent in what works for you and what works for your site. But the nurses typically see the patient once a week. And that goes on for like 4 or 6 weeks. And when the patient's stabilized and their urine screens are negative and their quality of life is improving and they're looking for a job and they're back with their family and they're trying to get their kids back, things are getting better, you can decrease the frequency. Some patients need to be on weekly forever or for a really long time. And some patients say to you, I want to see the nurse weekly. I need to come here. This is part of my recovery process. And if that's the case, so be it, is how we look at that. But everybody's an individual, and somebody may struggle over a period of time. You may need to step back and, re-intensify, the frequency. Others may do amazing right out of the gate, and they are off and running, and, and they're on monthlies and random, and they're seeing their providers, and everything's fine. But everybody's different, and their environment and other social stressors will be factored into this. So these visits, though, some providers may want to see the patients more often. So some providers may say the nurse sees the patient every other visit until they develop a comfort level with the nurse as well. So this is everybody's learning, and especially as you're getting started, you may want to be more involved, and you may want to learn more about this. So you may want to see the patients more often. But some providers don't have that flexibility, and they don't have that time that they can allot to doing this. So if that's the case, and if that's how you want to practice, which is what we do, the nurses see them all the time, but they also work super close to the providers, and they curbside each other, and they talk by phone, and they send electronic messages through Epic, and we meet weekly. So there's all different ways you can do that. But that, again, is very case dependent or practice dependent on your setting and what is comfortable for you. So we also do weekly prescriptions. I can tell you that your show rate will be extremely high. Patients will show up. They will come in. This treatment is super important to them. And if they don't come in, they have withdrawals. And if patients want to be in treatment, they don't want to be in withdrawal because they don't want to be using. So we have a really good adherence to patients on this medication, but we usually give them prescriptions weekly. So their weekly script coincides with that visit. And when they come, then their prescription gets generated. But over time, that prescription will put it, don't know your state laws, but most states with a Schedule 3, you can put refills on the medication. So we might give them a weekly script over time and then stop putting refills so you're not haunting the physician or the provider to get that signature if you have to do hard copy signature. This is a controlled substance. Unless you have electronic prescribing for controls, you will need a hard copy signature for that. But we will increase the script to weekly with refills to 2 weeks, to 2 weeks with refills, to 3 weeks, to 4 weeks, again, depending on the patient. So the nurse will see the patient and follow up. And again, the providers may do this as well, but they're assessing how the patient's doing. How are they feeling? Are they craving? Are they having withdrawal? Are they having any side effects? Are they taking their medication? Is there buprenorphine in their urine? Are they going to counseling? And the hope is that they are going to counseling. But we will not discharge someone who's not going to counseling because we know people die when they're not in care. We will just continue to see them super frequently. But we will try to encourage folks to do that, as well as is there psychiatric issues showing up? Are we seeing that this person has psychiatric comorbidities that are now coming unraveled that they're not using, and you want to get them into care, because if we don't deal with this psychiatric crisis, we're going to lose them. We also start dealing with their medical issues and their vaccines and their Hep C and maybe getting that treated, and their diabetes and their hypertension and all those other things that patients couldn't take care of before because they were actively using. The nurses deal with the prescriptions, they deal with the pharmacies, the prior auths, making sure someone's not pregnant. If somebody is pregnant, getting them into care, and then helping with the social determinants of health, either themselves or using care coordinators and others in the team that can help with those issues. So we're monitoring patients through urine drug screening. Some folks will do pill counts. We don't do a whole lot of pill counts anymore because we have so much buprenorphine where we are that patients could literally, even the score in the lobby and rent some pills or rent some strips and come upstairs. And so there's really no point in that. But if somebody is actively using, those things are going to unravel over time, so we don't worry so much about that. You may do observed dosing. If somebody's actively using, they're not going to take buprenorphine because it's going to put them in withdrawal. Doing random callbacks is another way of dealing with that. The routine scheduled visits, checking in with counseling, not calling up the counselor and saying, so what did John talk about this week? But more about, are they going? Is there anything going on? And if you can get releases and consents to talk to family or support people, that can be super helpful as well. And again, it's not as a, somebody to rat on them. It's more about having somebody that they can, that can contact you if they're concerned, or that you can say, hey, can you just check in? Is everything okay? Because we want to, if we see signs that something's going on, we want to respond to that sooner rather than later so that there isn't a bad outcome. So again, counseling, referring to appropriate levels of care, a person who has psychiatric comorbidities, those with medical comorbidities, your adolescents, making sure that care is sensitive to the population we're treating. Persons over the age of 60, you may not want to be putting them into a group with young adults. That just may not work for them. Pregnant women may do better in a group with women who are pregnant or are postpartum or are parenting. And healthcare providers, not to be a forgotten group, healthcare providers are often struggling with substance use. Greater than 10% of the population, and a lot of that has to do with access and resources, have a substance use disorder. So making sure that if we acknowledge a provider who is struggling, that we help them get to care, but also understanding that groups won't be appropriate for them if you're seeing somebody who is a professional to go to a group that's not for healthcare providers for concerns over confidentiality. So again, we talked about this, so the value of treatment decreases costs and improves outcomes. Don't really need to go into that again. We know that patient-centered outcomes are comparable to those of physician-centered approaches, and I think whenever we use a complex care management approach and we bring all people in, we're going to get better outcomes. Using the complex care team is of best interest to all of us. It also allows all providers to work to the scope of their practice. And so providers aren't getting stuck doing things that they shouldn't have to do. Nurses aren't getting stuck doing things that they don't need to do. MAs, and so again, it goes all the way down. So MAs doing what they can do to help out care coordinators, recovery coaches, nurses, and providers. So we definitely need to think differently about how we take care of patients. Again, we're pretty progressive in Massachusetts at this point, really focusing on harm reduction, really lowering thresholds, keeping people in care, not like 3 strikes you're out, really trying to treat people on demand and utilizing providers from all practice levels and letting people practice to the scope of their practice, as well as using technology and other tools that we have in our toolbox to further expand treatment. So lowering the barriers and extending people, engaging people into treatment. There's lots and lots of resources out there, so really being sensitive, really being aware of what those resources are. SAMHSA has amazing tools. There's a treatment located, there's these pocket guides you can see on the left-hand side here. There's one on opiate use disorder, there's another one on alcohol, that's a spiral bound. These things are all free and accessible. There's mobile apps that you can utilize. There's, let me just find it, whoops, this one. This is if there's anything you're gonna get that really can help you in the practice, it is this. This is the tip 63 that literally just came out a few months ago, and this is from SAMHSA as well. You can go onto their website, you can look it up, and you want to get the hard copy, you want to order it. It's a pretty heavy book, but it's extremely helpful. Lots of clinical guidelines and tools in there, really well referenced, easy reading, sectioned off really well, very harm reduction focused language and what have you. Just a really well done document that can provide you lots and lots of information on all 3 of the medications for opioid use disorder. So nurses are a great tool, and I would encourage you to use them, again, letting them practice the scope of their practice and helping you manage patients with this complex disease. Another amazing tool is Harvard Global Health with NIDA. The National Institute of Drug Abuse funded this. They put together 24 separate 1-hour modules, and these 1-hour modules are CME and CE accredited for nurses, social workers, and providers. And so you can go into this toolbox of modules and you can pull out, you can watch 1 or 24 of them. If for each one you get the credits. They're self-paced, and there are tests associated with them, but they're free and they give you credits, and they also give you knowledge. And so the first set is more about the disease and the physiology of substance use disorder and the data. The second group is really focused on the behavioral health component. Joji Suzuki course led that group of modules, a lot on motivational interviewing and on psychiatric disorders and anxiety and co-managing patients with substance use disorder. So it can be really valuable, especially if psych is not your specialty. And the third set is one that I co-led, which is on the nurse care manager model, which gives more detail on the different components of the nurses managing this. But again, it's great to find our resources and our tools, especially there's so much available out there that's free. There's really no reason to be paying for education at this time, at least, which is really a great thing. The PCSS, which is the Provider Clinical Support System, another amazing place to go where you can find just so many resources, clinical guidelines, modules, webinars, all sorts of resources that are there, as well as vignettes from patients and caregivers on topics of substance use and stigma and harm reduction. But again, lots of things that are there that are free. Lots of them have CEs and CMEs attached to them, as well as information on waiver trainings if there's providers that are looking to do that. There's also there's a resource tab, which our tools are under that resource tab as well. And I think I might have skipped putting our website in here. So our website is BMC, OBAT, O-B-A-T. So it's BMC, Boston Medical Center, OBAT, as you see at the bottom of the screen here, obat.org. When you go to that website, you'll see a resource tab, and under the resource tab, you'll see the clinical guidelines and our tools and other resources. We do lots of training, but they're Massachusetts-based, but you'll see our resources there as well. This is a word cloud we did from our patients, and I think it's valuable to just see what doing this work means to those we care for. Like I said, not have to choose between drugs and my children, people getting their lives back, and what the benefit these providers have on patients' lives. And one patient says, this place is like my oxygen tank. So, treating this disease cannot be underscored. Dan Alford, who's one of my amazing mentors and who guided me through learning this for many years, said to me one day, he says, Colleen, I'm not a surgeon, I'm not a cardiologist, I've never saved anyone's life. I'm an internist, and I've never felt that until I treated someone with substance use when a patient said to me, Doc, you saved my life. And I just want to leave you with that. This is really valuable, important work, and you can make a difference in people's lives in treating this. These are just my little overdose. International Overdose Awareness Day is August 31st. And these are just posters from last year's overdose campaign, and you can actually go to the International Overdose Awareness Day website if you want to pull some tools out and maybe put some things together for your site and raise awareness and start talking about it. Also on our website, where the address I just gave you is a lot on Words Matter and campaigns and using words and pledging to treat patients with substance use with dignity and respect. And again, you're welcome to use and share anything there that's helpful. And I will stop there so we have time for questions. Sorry I went fast. I just think letting you guys talk is more valuable than me talking at you. So if you want to unmute your site there, and we can have some questions.
Okay. That was awesome. Thank you.
Thank you.
Oh, yes. One question was, can we get your slides?
Yes, I think Debbie will probably send them to you, but if not, I'm happy to do so.
Yes, I have them, so I'll follow up with some of this information.
I have a question, Colleen. I know you guys have a very established program.
Yep.
With, a large team involved. You serve a large number of patients. Kind of per physician or per nurse care manager, how many patients do you guys start on MAT, say in a month? And how many of your internists or family practitioners, how many patients do each of them kind of have on their panel at any given time that use MAT?
Yeah, so I would say that our providers don't feel like they have to limit the amount of people they can treat. And the reason for that is because the nurses are doing the bulk of the lifting. So the providers don't feel overwhelmed by that. So essentially we just fit the patients into the provider's schedule. And so if they have a new patient slot and we have a new patient, we put, Debbie, are you muted?
No.
Can you mute yours? Because I think yours is giving a lot of feedback. Thank you. Sorry. I don't know why we're getting that. So we, sorry, my screen went crazy. So we essentially, the nurses are the ones doing the intake and the screener. They book them into the providers for follow-up. They book them for new patient slots, or they may even double book them, but they check with the providers before they do that. And we actually have such a high volume of patients at this point that we actually have some frozen slots in our provider's schedule so that we can put the OBAT patients in. So there's not really a limit in how many that they'll manage. I have some providers who have 5 patients. I have others who have 80 patients. We don't have anybody over the 100, and we don't need to do that because we have so many providers. We actually have 700 patients in our program, but we don't need to go any higher because we have enough providers to manage the caseload.
I have a question. Are you talking about these people, all of them heroin addicts? Are there also people coming from Vicodin and Percocet, opioid addiction? Like
So they're all patients with opioid use disorder. I don't think we can, I think the majority by the time they get to us are using injectable heroin or fentanyl or carfentanil. The majority, we do have some folks that will come to us from pain management providers, but I'd say greater than 90% of, maybe even 95% of our patients are injecting by the time we see them.
I have a question for you. For your clients that are coming in and they're actually starting out on buprenorphine, are they eventually transitioning over to naltrexone or Vivitrol?
Are they eventually, is that the question? I'm sorry.
Eventually transitioning from taking Suboxone and then eventually utilizing naltrexone and Vivitrol. Is that your goal?
Our goal is to meet the patients with what works for them. And if they're on buprenorphine and they're doing well and that's keeping them well and they're feeling comfortable on that, then we keep them on the buprenorphine. Some patients will be on this for the rest of their lives, like they will be on other chronic disease management meds. Some patients will come in and say, I just want to be off everything. I want to get on buprenorphine and I want to get off everything. We'll say, okay, let's do 6 months and stabilize you and help you improve your quality of life. And then let's go back and figure out, that let's help you with your goals. And then what often happens, the majority of patients have never been doing as well as they're doing now, and they don't want to come off their medication. And I would say that there is a small subset of patients that ask to transition from buprenorphine to naltrexone, but it's more the exception than it is the rule. And again, we'll meet patients where they're at and we'll help them do that if that's what they choose to do, but it's not a common thing. I think we may see a difference with the new subblockade, which is the depot of buprenorphine that's just been approved. And that has a long half-life that is cumulative, and that once somebody's been on it for a period of time, it actually, if they stopped it, they can potentially, it seems like it may help them self-taper. So we may see more people using that and wanting to get off, but we always worry about, what happens when somebody stops because the outcomes are not that great.
My second question for you is, when your clients come in, they have to be waivered. Did I understand you to say that they have to be waivered, of course, through SAMHSA, or here it has to be through SAMHSA to admit the doctors to administer buprenorphine, but with naltrexone, your doctors don't have to be waivered?
Yeah, so naltrexone doesn't have any additional level of training or certification for providers. Anyone who has a prescriptive authority to prescribe any medications can prescribe buprenorphine. Okay, prescribe naltrexone, oral or injectable. No waiver.
Can I ask a follow-up question to Cassandra's? In those minority of patients that are doing well on buprenorphine and do want to try transitioning to Vivitrol after they've been stable for months, things are going well. At what rate do you taper their buprenorphine on the way to getting them prepared for the naltrexone challenge?
Sure. So again, we would do that on a per patient. I mean, we would try to taper them down from 8 milligrams and then go, a couple of milligrams every couple of weeks. But if the patient started being symptomatic, we would slow that down further. So we would do it with the patient's guidance. They may need comfort meds. I can tell you it's a really hard thing to do. You can get somebody down to 2 milligrams, and it's really hard to get them off that last couple of milligrams.
Right. Yeah.
I don't think anyone's figured out the magic potion here.
Yeah. Yeah. Okay. Great.
Yeah. So I was thinking the subblockade might actually help with that, because we've heard some anecdotal reports of folks getting subblockade in the trials and then ending up incarcerated. And then while they were incarcerated, the sub-blockade clearly wore off, and they didn't feel any symptoms of withdrawal.
Cool.
So I'm thinking that might actually help.
Can I clarify something about your schedule? So when you said that you're putting patients into the provider's schedule, that's just their regular primary care day. So if it's like
Correct.
an open spot, that's kind of awesome.
Yeah, it is. I mean, everybody does it differently, but the providers don't feel like they need anything extra. Actually, they love seeing these patients because they're pretty well tucked in, and the nurses are doing the chronic disease management on the other end.
I love that.
Yeah.
Do you have all of your providers that are prescribing buprenorphine, are they given the nursing support? Are they all doing both inductions and maintenance, or do you ever have some doing like inductions and then more they doing maintenance? You know,
The nurses are doing the induction.
okay, so just
So they're just seeing them for that initial visit, and then in between just to check in, as well as for any acute things or any medical issues in addition to their opiate use disorder. But some providers may want to see them more often. Again, that's a case by case depending on what the provider's level of comfort is or what their level of involvement is.
and I think for us, some of that might just be logistics too, basically.
Oh, absolutely. And I think that's what happened with us. It was logistics. Like in an academic medical center, how do you get a provider who's in clinic once a week to see these patients? It was almost impossible.
So when these patients are coming through the detox and coming to you, instead of buprenorphine, can I just use naltrexone? It doesn't matter, or do you have any preference which patients get buprenorphine, which patients get naltrexone?
Our patients are more often wanting buprenorphine than they are naltrexone. With naltrexone doesn't really treat the cravings of the withdrawal, it's the blockade. It's a pretty hard sell for patients. And where we've seen naltrexone used a lot in this state, and I think in others, it's in the criminal justice system, where they don't worry so much about this one because it's not an opioid. But a lot of patients are really not comfortable on it. So it's more the patients driving the train of what they want for treatment. And a lot of our patients don't go to detox. A lot of our patients come to us straight from the street they're actively using. It is more challenging if you're going to use naltrexone to take someone from the street and transition them, because they got to be 7 to 10 days opioid naive, or you'll put them in withdrawal. So that person is better off in a controlled setting to keep them safe and to try to get them opioid naive before starting them on naltrexone. That's why I think the criminal justice is why it somewhat works, because many of them are not using, not all of them, but many of them aren't.
I have another question for you. Have you heard I was watching 60 Minutes. They were talking about a physician, a private practitioner, who was utilizing naltrexone implant. Have you heard anything about the implant?
Yeah, so the implant was out for a while and then it seemed to disappear. Was this recently?
Yes, it was just recently. I saw about 2 weeks ago on 60 Minutes.
Yeah, we haven't seen it recently. There is a buprenorphine implant as well. You're not talking about that one, right? The rods. Yeah, the naltrexone one, where I haven't seen it rearing its head again. It was out a while ago, but nobody was using it. But maybe it is coming back. I'll have to check it out.
You guys use the rod, or is that off the market?
No, the rod is on the market. It's just that it hasn't gotten off the ground, and I don't even know if they're manufacturing it at this point. There was struggles with the cost of it, and then the cost of the implant, and then people weren't able to make their cost up because the drug itself was like $5,000. But it's for a 6-month implant, and you have to go through this training to become certified to do this implant. And you also have to be somebody who does some type of surgical intervention, whether it be sutures or LARC procedures or something like that, every 90 days in order to be doing them. And you can only use the forearms. You only essentially have 2, maybe 4 spots. They were talking about the thighs. So it was a little tricky. And I just think it was too complicated for folks.
I've just been doing this for a year here at our site, but I've been reviewing your website and your national guideline and all of your checklists. It's a fantastic suite of resources for us. Thank you very much.
You're welcome. My pleasure.
And one of the things that I like about it is that it does not limit itself in terms of buprenorphine induction, Suboxone induction does not limit itself to the FDA guidance, which is max 8 milligrams on the first day.
Right.
And that's just one caution I would offer about, and maybe you've seen this too in your practice, about recommending the SAMHSA tip 63.
Mm-hmm.
It is still stuck. Yeah, I mean, it says individualize the dose, but it's still stuck on that FDA limit. And when I started doing MAT here, basically because of that, that's what I was told makes sense. But the majority of patients coming to us who are actively using heroin do end up, the majority of them end up on more than 8 milligrams on their first.
Yeah, no, it's a great point, and then also the purity of the drug that they're using out there and the fentanyl and what have you is so much stronger. I mean, you want to get them on treatment and staying as opposed to losing them.
Exactly right. You want their experience on the first day. You want them to have an experience that this actually works. And the other thing too is the SAMHSA guideline tends to say wait 2 hours between doses. 30, depending on how the person is doing, 30 minutes.
Yeah, 30, 40 minutes, you're good.
Dosing interval, and your guideline includes that. So
yeah,
I think your guideline is better than tip 63.
Well, thank you. We're actually taking the guideline and making some logic models because we know providers are super busy. And if you have a question about something, you're not going to be able to sit down and read through a book. So we're putting that together, and that's going to go up soon too.
Great.
Could you share a little more about your urine drug testing, like what you test for, how often you test,
Sure.
instant cups, how do you
Sure. So this happens differently. Like at our site, we're a hospital-based site, so everything has to have the quality metrics, and it makes things complicated. So point-of-care testing where we are is like a burden. So we do all lab testing at our facility, but a lot of the health centers do point-of-care. So I'll talk to you about both. So in our setting, we test for opioids, methadone, buprenorphine, cocaine, benzodiazepines. What did I skip? I don't know why barbiturates are on there, but they are. So that's what we test for routinely. Oh, in addition, methadone and fentanyl.
What about oxycodone?
Oxycodone, that's what I skipped. There's the 8. And so we do that routinely on everyone. If our patient were to come in and tell us they were using a different drug, we would add that. We do not test for marijuana. It doesn't mean we don't ask. We ask it all the time, and we talk about it all the time, but we don't test for it. And that is a lot of reasons, and also it helps if you have to, your patient needs a drug screen for something else, it's just not included there. It keeps things a little cleaner. We do not do GCMS testing routinely, so we don't do the confirmation testing unless there's a question or a need, because it's an expense that doesn't really need to happen all the time in our estimation. We use the urine as a tool. The urine just helps guide your care and your treatment, and the patient and what you're seeing before you and the behaviors and what's going on and whether they're coming in or not coming in or losing their scripts and all that is going to tell you a lot more than just that urine. We do a temp strip on our urine. Our urines are not observed, although the medical assistant is outside the door. The patient hands the urine over before they wash their hands or flush, and there's no basket in the bathroom, and they leave their belongings out front. And so that's about as close as we get to trying to make sure the urine is their urine, but that's not always foolproof. Excuse me, but again, it usually sorts itself out. A lot of the health centers do point-of-care testing, which is a great tool because you can have a real-time conversation with your patient. We definitely worry when we send a patient home and then we get a fentanyl that comes back because we look at that as a critical lab value. And so we want to get a hold of that person and hope we can reach them because they may not even know that they're using fentanyl. The health centers do point-of-care testing, but the problem is that there's no point-of-care testing that has a clear way for fentanyl, which is a huge problem. But there are strips that you can buy to test for fentanyl. The problem being also is there's a lot of false positives. There's so many analogs to fentanyl. So it's not confirmed. It's just you may have fentanyl in your urine, and and if a patient's been using, they'll probably talk to you about it if you're talking to them about the fact that you're concerned. But they will send their urines out if they come back positive for fentanyl to confirm it.
So I'm a little unclear still. So you are using point of care testing in your practice or no?
So at Boston Medical Center, no. In our health centers, yes, but not in all of them.
Okay, so in the health centers, we've been having trouble figuring out which particular product to use to get a reliable point of care test.
Mm-hmm.
I'm wondering if you can tell us exactly what is the product that you guys use in your health centers.
Yeah, so I'll have to get the name for you, but there is a ClearWave. There's a couple of ClearWave ones the health centers are using, and I can get that to Debbie to get to you. But again, there's not a ClearWave one for fentanyl.
Right.
But we do have a strip for fentanyl, and we can give you that as well. But that, again, is not 100% foolproof.
That would be really helpful.
Sure. And so the other piece of that question was, how often do you do urines? We see our patients usually weekly at the very most, so we do a urine at each weekly visit. I know urine is like liquid gold across the country. It's kind of a loaded thing at the moment because a lot of people have learned how to make money off of this disease, and one of the ways they're doing it is with urine. And that's sending it for GCMS testing and all these other complicated things and doing like 20 panel tests. And so we really try to minimize that and only do what's needed, again, because we use it as a tool. But we won't do 3 times a week, and we won't sign it for like residential treatment programs, like lab slips people want you to sign for testing to bill insurances. We won't do any of that.
Can I ask you a question about Narcan scripts? Does everyone in your programs kind of just get a Narcan script?
Yeah, so we'll send it down with the first buprenorphine. We don't need a script, but having it filled with the buprenorphine makes it more likely that the person's going to pick it up. They can go to the pharmacy and just get it because it's over the counter, so to speak. And it will get billed to their insurance. There's no cost associated with it unless they have commercial insurance. There may be a copay depending on the commercial. But yes, we try to give it to everybody.
Massachusetts, to Missouri.
Massachusetts, yeah. We're spoiled rotten.
In this clinic, we give Suboxone for chronic pain and mad heroin addicts too. Do you treat those people anything differently when the people are coming for pain, getting Suboxone, when people are getting Suboxone for the heroin? Do you treat them differently?
So are they chronic pain only or chronic pain and opiate use? I didn't hear that.
Yeah, opiate, not heroin by itself, but we're talking about Percocets and Vicodins. They're using.
But did they have an opiate use disorder, or did they just have chronic pain?
Opioid use disorder for chronic pain, I think. I don't know. Maybe
then yes, we would treat them. Then we would definitely treat them the same. They have an opiate use disorder. They just fortunately didn't progress to injecting heroin.
Yes, they're not. Most of my patients are.
Yeah. So I mean, you still want to monitor them. They still are at risk for a potential relapse, and they still have a substance use disorder. So yes, we would treat them the same. Don't differentiate. I think monitoring is of value, and it helps them with their disease because it's not just about the drug. It's about, a lot of our patients have had trauma and have had abuse and have depression and have been self-medicating and self-regulating. And so trying to help them through that, I think, is what we're trying to get at. So by wrapping around this complex care management team that can be available to them and tuned into those things is only helpful.
Colleen, can you, and I may have missed this, can you speak to who else is on that complex care management team? Like, who are all players?
Sure. So the nurses are the mainstay. So we have 9 full-time nurses. We have 2 care coordinators who help with housing and the insurance issues and appointments and help connect them to recovery services. We have a medical assistant who does a lot of the vital signs and the urine screens and sends them off to the lab and opens the notes and inputs it into the computer and helps with appointments. And then we have a behavioral health team that sits beside us that we hijack all the time. And we have a psychiatrist who sees our patients 2 sessions a week.
Oh, you have a psychiatrist also in the same clinic then?
Oh my God, yeah. It's like dying and going to heaven. It took a lot of years to get there, but we're finally there.
But most of the time, because we are family practitioners, we are doing the psychiatric care ourselves.
Yeah.
So
Yeah, no, I mean, it's a big issue. We're actually trying to build, a lot of us are trying to build like these telehealth systems for folks such as you, where you would have like a provider, a psychiatrist you can bounce things off of to get some guidance, because it is complicated, as you well know.
What the nurse care managers that you have doing the most technical, the most clinical work, you know, was the medical screenings and managing the induction of Suboxone. When you are, what background or training or level of experience, or maybe you have this in writing, sort of a job description, and if we want to hire somebody to do it, what kind of background do they need in order to function well in that position? And I don't suppose we could, I don't know how we compare Massachusetts to St. Louis, Boston to St. Louis. How much do you pay them? Because, so in terms of the details of actually getting qualified staff to work with us in this way, it seems like that would be important information.
Mm-hmm.
Yeah, no, it's a super important question. We have job descriptions we're happy to share. It was a hard hire for us in the beginning in trying to find those right people, so to speak. But now everybody wants to be engaged in substance use, so it's become a little bit easier. But I mean, I've gone both ways. I mean, I have 9 full-time nurses. My team is amazing. You know, and that's why it works. Our team is unbelievable. And, but it's people that are vested and committed and passionate. And if they didn't know about substance use, they wanted to learn it. And, you know, and so we did have some that came from a substance use background. I have one that came from inpatient detox, somebody who's done methadone, another one who worked in criminal justice. And then I have 2 brand new grads that we pulled on that were just wanted to do this work, who are phenomenal. And one of them went on to get her NP and then to get her waiver. You know, and so it's all different levels, but if you're just starting out, it would be super great to get somebody who has some addiction background. But again, you need to get somebody who's engaged with the medical model and not somebody who's abstinence-based. So, I mean, it can be challenging to find that right person. We're happy to, if you want, to do some like Zoom conferences with you for hiring, if that would be helpful, as well as to share with you questions that we ask for nurses, because we're actually been helping hire these 6 states, Michigan being one, Houston, Miami, or also Washington State, and New York, with these nurse models that are part of the PROUD study. So we've helped do that for them. The other thing is, if you wanted to and had funding to do it, you can send your nurse, if you get somebody, to Boston, and they can, you know, shadow in the clinic. And I think there's so much value to sitting with the nurses who see literally patient after patient after patient all day long, and then figuring out what you can take back into your system and what you can use from that would or wouldn't work for you.
That would be wonderful. And you did give the webinar information from Harvard for continuing education.
Yeah.
A nurse is hired that doesn't have as much substance abuse background or more education. Are there other continuing education credits or programs, either online or?
Yes, so the PCSS has lots of webinars and modules and clinical tools. SAMHSA does lots of them as well. ASAM does a lot. There's a lot of different things. There's so much out there right now. It would depend on what they wanted to learn about, and I could certainly direct you more specifically what the areas.
Colleen, could you just speak a little bit more about, just going back to your behavioral health team, can you speak a little bit more about how you utilize them and what they're kind of doing?
Yeah, so we have some behavioral health therapists who see patients for therapy. We also have the psychiatrists who see them for the med evaluation as well as the medication adjustments. So, I mean, there's just so many patients. The psychiatrists don't see them ongoing unless there's something, you know, truly acute or somebody who needs that level of intensity.
Do your psychiatrist see all of your MAT patients?
No. Just those who have a question, have an issue, something's going on, have a history, are exhibiting symptoms of something. But actually, one thing that's interesting is a bunch of my nurses are all going back to school to get their psych NP, and so they're starting to work with the psychiatrist, which is pretty cool.
And I'm wondering if you have experience with incorporating mind-body self-care skill training as part of the behavioral component in your treatment?
Yeah, so I mean, that's an excellent question. We also run on these state-wide conferences for the nurses in that 42 health centers, which brought together like 170 people. And at that, we did a mindfulness training. And one of the Zev Shulman, who's written on this, published on it, did the training for us. And I also worked with him to submit a grant to, I think it was an NIH grant, for mindfulness into the community health centers with patients with opiate use disorder and anxiety, and it got approved. So we're about to roll that out into 3 of the health centers, which will mean putting the staff there and here where we are through this week-long training on mindfulness, which is just awesome. So we're just getting there.
That's great. So over the course, like I said, I've just been doing this a year, but I have a background in mind-body medicine. And so in our, with patients that got onto Suboxone, when they had sort of gotten, kind of stable after a month or so, and they were coming weekly or every 2 weeks, I would tell them if they wanted to come back, they could, for their follow-up visit, could be a one-on-one individual visit with me, like, conventional, or we could do it as a small group visit where they could join some of their fellow patients, who are in a similar spot. And so then, I would have 4 to 6 patients that would be coming during the same hour and a half. And I would use about, 45 minutes or an hour or so to work with them as a group, and they would learn by practicing during that group visit one of a number of mind-body skills, different meditation practices or relaxation response practices. And about half the patients definitely preferred that to the individual visit. It seemed to be fruitful.
That's great.
So, but doing it as a group, as integrating it with their follow-up visit, is sort of a way to keep up, productivity.
Sure. Yeah.
But also for time for patients to do that.
Yeah, and then you give them a skill that they can take into their lives to deal with the stress and the issues that they encounter. It's great.
Right, so much stress. There's this sort of honeymoon right after they get off.
Oh, yeah. The pink cloud.
They're starting to live.
Yeah.
Fighting to survive. But then pretty quickly, they're slapped with the same reality that in part,
right,
got them into the rut of addiction in the first place.
Right.
It's a steep climb for these folks.
Absolutely.
In our contemporary society.
Yep.
Colleen,
I know, it's great.
Colleen, I have a question for you. It's kind of piggybacking off of what Dr. Curry is saying. in your practice or your program, do you also incorporate case management where you're building partnerships as they come in to bring services to your clients? As you mentioned before, helping clients get a better quality of care, getting back to normalcy of life. Do you find that it's difficult once you've got them all clean and you've got them on the right path, they're coming in to see the doctor, and you've given them the resume, you're connecting them with resources? Have you had the problem of them actually utilizing those resources? And have you tried having partnerships where they come in as part of your group session? Or do you conduct group sessions? That's the question I'm going to ask you.
I'm having a hard time hearing you. I think your question was how you deal with concrete services. Was that it?
Quality of services after they've been cleaned, after they've actually received the care, but now getting them to the resources because you're trying to help them to contain the quality of care.
Mm-hmm.
Normalcy. Do you provide partnerships? Do you create partnerships to come in and conduct group sessions and bring services to your clients?
Do we develop partnerships with outside agencies? Is that your?
With outside agencies?
Yes, absolutely. So we use whatever resources, and we actually have lots of them. Again, we're super spoiled, but we complain a lot in Massachusetts. Don't ask me why. And the governor is actually signing an opiate bill as we're talking right now. So yes, we utilize partnerships. We have lots of memorandums of agreement of understanding with different agencies, whether it be drop-in centers. We have resource centers, whether it be to group therapy or just a place for people in recovery or people that are actively using can go. So yes, we develop lots of partnerships. We use care coordinators wherever there are. Medicaid is actually integrated a lot of complex care managers because we just moved into an ACO model of care. So they're obviously trying to decrease their costs. So they want to try to, how to wrap around a patient and get them the services they need now so as to prevent those bad outcomes later. So yes, we do that for sure.
And do you do group sessions as well?
Yeah, so we don't do a lot of groups where we are because we have so many patients. We do some, but not a ton. We manage adolescents and young adults too, and we do those on site because we try to keep our kids and young adults contained and not make them jump through more hoops because it makes it hard. We have providers across the street from us that do groups for our patients. And then a lot of our patients don't live near the hospital. And so if they live in a certain community, we help hook them up with services in those places. So everything is individual. We also, some of our patients do web-based therapy and counseling and support. People use apps. There's all different ways. Everybody's in a different space.
How long your program has been running? Like how often your patient comes after every 6 months? How are your schedules after 6 months the patients are in your program?
How long does it take them to get to 6 months?
No, once they finish the 6 months,
yeah,
system and they're stabilized on the medications. What is your scheduling system then when you see them every month, every 2 months? Do you
we see them every 3 to 4 months.
Every 3 to 4 months. That is for Suboxone.
That's with Suboxone, yes.
Some
of our patients more often, it depends, again, individualized care, but some of our patients are super stable and doing really well and don't need that intensity.
Do you do with even chronic pain patients?
If they're just chronic pain, you're talking chronic pain with an opiate use disorder, right?
Yeah, opioid use disorder.
Right. I can tell you, we don't differentiate.
Okay, you can give them refills according to you.
Yeah, so it's a Schedule 3, so you can put refills on that.
Not if it's for pain.
Yeah.
Yeah. Most of these are they're dependent on opioids for the pain.
Yeah, and if they just have pain and they don't have a substance use disorder, if it's just chronic pain and you guys were trying not to give them full agonists, there's Belbuca, which is another formula of buprenorphine that's approved for that. For pain.
Yes, we are giving the
Everyone, we're at the end of our time. So I know some of you may have other appointments or things you need to get to. Are there any last burning questions or Colleen, any final words you want to offer before we conclude?
No, I mean, I'm happy to follow up or do whatever helps you folks. And thank you for taking this on.
Yes, and we'll be talking with Dr. Tepe about, just kind of debrief this with Colleen and see if there's any further needs for Colleen to help any further. And I'll be working with her to collect all of the resources together and send them to you.
Yeah, and along that line, the resources, so we're thinking the slides, the job description, whatever would help with nurse care manager hiring. The
point of care urine testing.
Yeah.
like
Right.
so
products that you
company
could
product.
yeah, and I would, Colleen, I would be interested if you could just include in an email the little contact information or email address or whatever about that mindfulness integrated
Oh, it's yeah. Okay.
abuse disorder treatment. Yeah. Thank you.
Thank you
Thank
very
you.
much.
Thank you. Bye-bye.
You all have a good day. Bye-bye.
Bye-bye. Thank you. Thank you.
You were off to the side.
I was off to the side.
Thanks, Colleen.
Thanks.
So much, both of you. Really appreciate it.
All righty. Bye-bye.
Have a good day.
Oh, maybe.